Hello and welcome to this video on our submission to Healthcare Management Forum, Public Health Physician Perspectives on Developing and Deploying Clinical Practice Guidelines during the 2009 H1N1 Pandemic, published April 6, 2020. The H1N1 influenza virus spread across Canada beginning in July 2009. A vaccine had not been deployed until September of 2009. Clinical practice guidelines were being developed continually and collaboratively by local, provincial, and federal public health agencies in Canada, with input from international agencies, as the virus had been circulating internationally since March. Clinical practice guidelines. Clinical practice guidelines in this context refers to the evidence-based set of recommendations that guide the day-to-day decisions clinicians make about diagnosis, treatment, and outbreak control measures. Firstly, it's important to realize that public health officials make guidelines based off of ultimately incomplete information during an outbreak of a novel pathogen, and that robust collaboration across jurisdictions and organizations is key to the process. This leads us to the lessons we report in our paper. Balance consistency with adaptability. First lesson is, it's important to keep the messaging between organizations clear and consistent when making and deploying guidelines. Miscommunication between agencies or between agencies and clinicians can lead to unexpectedly variable practices between jurisdictions. At the same time, however, there should be a clear recognition that jurisdictions have different levels of healthcare capacity and different populations. There needs to be a level of adaptability in the process to account for distinct needs based on location. Consider the timeliness of the consultative process. The consultative process takes time and can be slow, considering the various levels of jurisdictions and organizations needed to develop robust guidelines. Guidelines should not be delayed, but also should not be updated at a pace that overwhelms frontline clinicians. Iterate on guideline development process. The guideline development process itself should be explicit and iterated on between outbreaks to make sure agencies can keep up to date on the changing cultural and institutional context.
Capacity is essential. Public health capacity should not only be an issue to deal with during an outbreak. There are no shortage of public health issues to work on at any given time, so making sure public health is well resourced in general will enable more health promotion and disease prevention priorities to be addressed between crises and reduce the chance of systemic burnout in a time of crisis. Build on existing public health structures. That being said, because the mandate is so broad and public health issues are evergreen by nature, there are already groups evaluating lessons learned and working on planning for the next event. These already existing groups must remain active and be leveraged, optimized, and scaled such that their expertise remains intact for when the process needs them the most. Create and maintain positive routine working relationships. The public health workforce is small, and as the last point emphasized, continuity in the process is key. It is important that individuals within public health across jurisdictions create and maintain robust routine working relationships, so when things get hectic, they are comfortable with each other's roles and abilities and can build on established trust to share data and best practices quickly to address emergent issues. Enable public health leadership. Lastly, it is important to enable the full scope of public health leadership. Public health physicians are uniquely skilled to understand infectious diseases and their social implications. They are trained to lead the public health response to emergencies and the programs and policies to improve and maintain the health of entire populations. They are also well known as a trusted source of credible information to the media and the public on matters affecting the population's health, and can lead efforts to provide ongoing communication on the state of the pandemic and how citizens can keep themselves and their communities safe. They should not be reduced to technical consultants during pandemics, but should be front and center to communicate to the public and given the authority they need to guide the community through public health emergencies.
We would like to acknowledge the Urban Public Health Network members in Vancouver Island Health Authority, Vancouver Coastal Health, former Saskatoon Health Region, City of Hamilton Public Health, City of Toronto Public Health, and Ottawa Public Health for contributing their perspectives to this article. We would also like to thank the peer reviewers who helped us improve our article, and Laurie Wilson, editor at Healthcare Management Forum, for guiding us through the process. Thanks for watching our video.